Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about gonorrhea. Gonorrhea is a bacteria. It's the second most common bacterial sexually transmitted infection right after chlamydia. It's estimated in the United States there are going to be somewhere between 800,000 and 900,000 cases just this year, and the World Health Organization suggests that there are going to be about 106 million cases throughout the world. That's a 20% increase since 2005, and since 2017 we've had warnings of spread of untreatable gonorrhea, mostly in Japan and France and Spain. But what happens there will unfortunately happen here. There's no protective immunity against infection. If you've had one infection, you're likely to get another infection. The peak age is adolescents and young adults. Seems to be most prevalent in women between the ages of 15 and 25, men between 20 and 25. But all ages who are sexually active may develop the infection. Traditionally, it's been more prevalent in the southern United States and in the African American community. But it now appears that the major risk factors are just being under age 25 and having new sex partners. Also, people who have sex with multiple partners, or sex with individuals who have sexually transmitted infections, or having multiple relationships and not using a condom, or having a history of a previous sexually transmitted infection, or exchanging sex for money or drugs, or being incarcerated, or being a military recruit, or attending a sexually transmitted disease clinic. And certain communities just seem to have more sexually transmitted diseases than others that put the people who live in those communities at greater risk. But right now what we find is that men having sex with men, the gay population, seems to be the reservoir. In 1990, only 4% of the cases of gonorrhea occurred in the gay population. Now it's more than 40%. And unfortunately, that's where an increased incidence of the antibiotic resistance seems to occur. And additionally, to make matters even worse, if you have gonorrhea, you're more likely to contract HIV. And if you have gonorrhea, you're more likely to pass HIV on. This is a human disease only. The bacteria lives either intracellularly or extracellularly. References date back to the Old Testament, one of the oldest known human diseases. It's called the clap by some people, from le clapier. That means the rabbit hole. Was the small huts there the prostitutes lived in the district of Paris. Got that name in the 1300s. Once you're infected, you don't get any immunity, and you actually can be a carrier. You might have no symptoms, but you might be infectious to others. The incubation period tends to be somewhere between about 2 and 14 days, averages about 4 to 6 days. Having one episode of sexual relations, well, if you're a man, you might contract it from a woman who has gonorrhea about 20% of the time. If you're a woman, you'll contract it about 60 to 80% of the time if the man has the infection. It can be passed on through sex toys and can live outside the body for minutes to hours. In men, typically there's going to be a urethral discharge and dysuria, pain while you're urinating. It's going to occur about 2 to 6 days after exposure. Only a minority of men are asymptomatic. Some men develop acute epididymitis, extreme amount of pain, typically between the ages of 14 and 35. Other cause is chlamydia. The gay population, the insertive individual can get a urethritis. The receptive individual gets a proctitis. People can get edema of the penis or lymphangitis or abscesses around the urethra or acute and chronic prostatitis or testicular pain. Women, probably somewhere in excess of 60 or 70 or 80% of the time, can be asymptomatic. The incubation period, again, is 4 to 6 days in there. Most common manifestation for those women who have symptoms is going to be cervicitis with vaginal discharge, often with concomitant urethritis, dysuria, burning when urinating. Sometimes, because the cervix is inflamed, there can be bleeding in between the periods or itching or pain during sex. We can have an ascending infection where the organism goes from the cervix up through the uterus and into the tubes. That occurs relatively commonly. About 20% of untreated women going to develop complications, most common complications, going to be pelvic inflammatory disease with systemic manifestations including fever and chills and nausea and vomiting and elevated white blood count. Other individuals develop vaginal discharge and bleeding and pain during sex and pain urinating and complications of inflammation of the lining of the uterus, we call it endometritis, or of the tubes, we call it salpingitis or tubo-ovarian abscess. Some people develop pelvic adhesions or perihepatitis or peritonitis. Involuntary infertility if a woman goes untreated, about 15 to 30% of the time. It's tubal factor infertility. Can be up to 85% of the time in sub-Saharan Africa, and that can lead to ectopic pregnancy. The rate of co-infection with chlamydia is anywhere between about 20 and 50%. Screening probably makes sense in sexually active women who are less than 25, older women if they're at increased risk if they have a new sex partner, pregnant women at the first visit to see the doctor, and if they have any additional risk factors ought to be retested in the third trimester. People in correctional facilities, women less than age 35, men less than age 30, probably ought to be screened. And certainly yearly screening at least for men having sex with men who are sexually active should be tested in the urethral area, the rectum, and the oropharynx, the mouth, the throat, the back of the throat. High-risk men who are having sex with men, maybe the screening can be every 3 to 6 months. The United States Preventive Services Task Force says in the general population, probably screening isn't necessarily appropriate, but for those at high risk, a nucleic acid amplification test, the NAAT test, that seems to be probably the best we have at the present time. We can test the urogenital sites, we can test even the urine. We can test the endocervix or the vagina or the urethra itself. It's unapproved, but still widely used for the rectum and the throat, the oropharynx and the conjunctiva. Unfortunately, the test can be falsely positive in a low-risk population, falsely positive in the oropharynx because there are other Neisseria present. So we need a confirmatory test at times, and it's less accurate in the urine than it is in the vagina or the endocervical area. But under any circumstances, the nucleic acid amplification test is more sensitive than the culture. If a man has an infection and has a discharge, we can test the discharge right there. We can do a gram stain. We look under the microscope and we can see the organism inside the white blood cells. Can't do that in asymptomatic men. In women, the genital swabs don't seem to be of any value. If there's a positive test, then we should test for chlamydia, we should test for syphilis, we should test for HIV. The organism itself doesn't like too much oxygen. It likes a little bit. It's what we call a microaerophilic organism. So it's different than the standard organisms that require oxygen, and it's certainly not an anaerobe that hates oxygen. But this organism is fastidious, so it's very difficult to grow it. It has certain virulence factors that it can switch on and off depending on the body's immune system. So it subverts the body's immune system, and it can survive in the white blood cells that would normally go and kill it. It has a variety of virulence factors. We call them type 4 pili. They're hair-like appendages that are required for attachment to the mucosal epithelial cells. There are other virulence factors. There's OPA, the opacity protein associated, or there's the pore protein. That counts for 60% of all of the protein in gonorrhea. And then there's the lipo-oligosaccharides. Well, these are important because what they do is they cause the attachment to the cells, and they cause invasion of the cells, and they allow the cell to grow inside the human cell. Now, the human cell, under normal circumstances, when it's invaded, is going to produce some free radicals. It's going to produce superoxide anion, it's going to produce hydroxyl radical and hydrogen peroxide. And that's going to deter the organism. But what gonorrhea does is it produces its own catalase, so it gets rid of the hydrogen peroxide. It's important that it gets rid of the hydrogen peroxide because the hydrogen peroxide prevents the organism, prevents the gonorrhea organism from getting iron, and the gonorrhea organism needs iron. Now, there are extragenital sites, so we talk about the anal rectal area. It's very common in men having sex with men, relatively common in women. Some can develop acute symptoms, acute proctitis, anal itch, rectal pain, discharge, straining when having a bowel movement, increased likelihood of acquiring AIDS. Men get it from unprotected anal intercourse, women the same, but additionally, it all depends on contamination from cervical secretions that may allow passage. There's a problem with oropharyngeal, the back of the throat, gonorrhea. It can cause pharyngitis at times, but it's generally an asymptomatic infection. It's readily detected in expectorated saliva. It's an important role of transmission. You can transmit the infection higher risk with fellatio than there is with cunnilingus. It can be transmitted from the mouth to multiple different sites, can be transmitted to the male or female urethra, can be transmitted to the anal rectal area, or can be transmitted from mouth to mouth. Screening for oropharyngeal gonorrhea is important, especially in men having sex with men. Culture isn't very good, but we can do that nucleic acid amplification test. That's the treatment of choice, even though the FDA hasn't approved it for that purpose. But it is a very valuable test. And it seems that it's the oropharynx because we have normal Neisseria present, other than the gonorrhea. Neisseria is also known as Neisseria gonorrhea, but we have a lot of Neisseria that aren't gonorrhea. And as a matter of fact, one of the forms, meningitis, Neisseria meningitidis. So it seems that we can have exchange of the chromosomes inside the mouth, and that might lead to an increased incidence of resistance. Now, when a person does develop an oropharyngeal infection, unlike in certain other areas, it seems to be self-curing in a period of time. So after about 6 weeks, about half of the cases self-cure. After about 12 weeks, most or all of the cases self-cure. Now, unfortunately, penetration of the antibiotics into the mouth, into the oropharyngeal cavity, relatively variable, complex area, much lower cure rate than either the genital area or the rectal area. We can't achieve as high a concentration of the antibiotics. The prevalence of infection of the oropharynx in men having sex with men is about 3 to 7% versus less than 0.5% in men having sex with women or women. Well, other area where the organism can go is around the liver and cause what we call a perihepatitis or the Fitzhugh-Curtis syndrome, pain in the upper right quadrant, tenderness in the upper right quadrant. This occurs as the organism ascends from the cervix through the uterus and the tubes out into the peritoneal cavity and then congregates around the capsule of the liver. And in babies who are born through infected birth canals, there's a potential for gonococcal ophthalmia neonatorum, in other words, infection of the conjunctiva. That's if the mother has the gonorrhea, the baby is born vaginally. Unfortunately, if it's not treated prophylactically, can lead to blindness, corneal perforation within 24 hours after delivery. In most states, mandate therapy with something. Typically, it's erythromycin or tetracycline or povidone iodine or silver nitrate. We worry a little bit about resistance, but that hasn't seemed to be much of an issue so far, at least as far as the eye is concerned. Well, eye infections may occur in adults, in sexually active adults, but it's relatively rare. So we don't tend to test for it. But if a person has conjunctivitis and doesn't seem to get better with standard therapy, then a culture seems to be appropriate. And sometimes the organism can get into the bloodstream. It gets into the bloodstream from any mucosal site, whether we're talking about the urethra, the cervix, or the rectum. And once it does, it can disseminate. It's relatively unusual, but it's more in women than it is in men. It tends to occur about 2 to 3 weeks after the primary infection. Cultures are done, but the cultures frequently are negative, so we have to do a lot of cultures, at least 3 blood cultures. And if it gets into the joint, we do a joint culture. But perhaps of more importance, again, the nucleic acid amplification test at all of the sites, we find that only certain strains of gonorrhea are able to become disseminated. There are 2 different stages of dissemination. One we call the arthritis dermatitis syndrome. This is associated with high fever, aches and pains in multiple joints, tenosynovitis at your elbow and your knees and your joints of your hand, sometimes painless skin lesions. Complications may occur, can cause an infection in the heart valve, endocarditis, infection in the bone, osteomyelitis, infection around the brain, meningitis. Second form is a localized stage, localized to just one joint or a few joints, what we call septic arthritis, without the skin condition, without the polyarthritis, without the tenosynovitis. And in pregnant women, there's an issue, chorioamnionitis or premature rupture of the membrane, preterm delivery, spontaneous abortion, septic abortion. And for the newborn, there's always a risk, blindness and conjunctivitis if not treated, sepsis, get into the bloodstream, meningitis or arthritis. And now we have another problem. We have the problem with the antibiotic resistance. The organism is becoming increasingly resistant to all of our antibiotics. It's resistant to the sulfonamides, increasingly to the penicillin, sometimes to the doxycycline, tetracyclines, to the macrolides, erythromycin, azithromycin, clarithromycin, to the fluoroquinolones, Cipro and Levaquin, and even to the cephalosporins. So that's not leaving us with all that much. And we know that the gonorrhea that happens to occur in the mouth, that seems to be central in spreading the resistance. And that's a reservoir for asymptomatic infection. So after a person has been treated for the genital disease or the rectal disease and we think we've cured them, why not be cured in the mouth? And then the person is still infectious. It's gotten to a point where in 2015, 2016, the Centers for Disease Control and the World Health Organization said, hey, 2 drugs to treat the condition. No more of these one-shot deals. So you get ceftriaxone combined with azithromycin, 1 dose of each. They have different mechanism of action, so that's going to hopefully decrease the likelihood of resistance. So for uncomplicated urogenital or rectal or oropharyngeal or conjunctival infection, dual treatment, you get ceftriaxone. In the United States, we use that 250 milligram intramuscular dose. In Europe and Australia, these 500 milligrams. If that's not available, we use cefixime. We use that orally, 400 milligrams. And then we combine that with azithromycin. Here in the United States, we use 1 gram, 1 time, once. In some areas of the world, they use 2 grams. If you have azithromycin allergy, then we're back to doxycycline. We use that for 7 days. So if you have the infection and are treated, we say don't have any sex for 7 days or until you're asymptomatic for at least 7 days. We don't have to repeat any testing if you have uncomplicated disease and you seem to get better. Now, if you had oropharyngeal disease and you got treated with some alternative regimen, then you have to repeat the diagnostic test, the NAAT, at 14 days. All patients should get retested about 3 months later. Most people who seem to have what we call refractory disease at the present time in the United States, that's because of reinfection. That's not because of treatment failure. Now, if you have sex partners within 60 days, those people should be contacted and evaluated and, if appropriate, treated. And if you haven't had any sex for 60 days, then the last person you had sex with should be evaluated. Early detection means less time that the organism is around, and that means there's less time for it to acquire resistance. So we can envision a time in the foreseeable future when gonorrhea is going to be untreatable. So there you have it, gonorrhea. It's a common sexually transmitted disease. Right now, it can go not only in your genitals, but also to your rectum, to your throat, to your joints, especially to your knee. And unfortunately, a lot of people, especially women, can carry the organism and pass it on without even knowing it. And also, unfortunately, it's getting to be where our treatments don't seem to work very well. Anyway, Thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you can be updated when we post a new show. And as always, I appreciate your time. Thank you. I'm Dr. Ken Landau.